Right, everybody, welcome to the fifth BAPO webinar. This time it's all about ears, tympanic membrane perforations and retractions, and a little bit about cholesteatoma as well. I'm just getting the tech together for a minute. There we go. So in Bristol, throwing statues into the harbour is really a well accepted pastime, passed down from generation to generation. So I've got a high quality panel of statue tossers arranged this evening to help us talk about ears. The first one, Adrian James, is now a very famous international professor at the Sick Kids Hospital in Toronto. He was for a few years a colleague of mine at Bristol Children's Hospital, where I took it upon myself to teach him everything I know about paediatric ENT, which took about 20 minutes, or maybe 10, and then he moved on. The second panel member is Susan Douglas, who's also an old former Bristol consultant, and I taught her everything I know about otology as well, which took about 35 seconds. Susan's now in Rotherham, and Susan was the Graham Fraser Cochlear Implant Fellow in Sydney before she came to us. Third panel member is has grown up throwing statues all of his life, going to Bristol Cathedral School, and he's now settled in Southampton, where he's a otologist and paediatric ENT surgeon, and he's also the treasurer of BAPO. The last panel member has no real connection with Bristol or statue tossing, but I know there's a statue of John Mitchell in the city centre, which he's had his eye on for some time, and I imagine after tonight he's going to be toddling off down and chucking it in the harbour. I used to be able to keep up with him on a bike, but that was a long time ago. That was about 2009. I could last keep up with Keith Trimble from Royal Belfast Hospital for Sick Children, who actually did a fellowship with Adrian in Toronto. He's been a council member of BAPO for a long time. Right, that's me. It's traditional to have someone on the panel who plays the village idiot, who doesn't know anything, so that they can ask the embarrassingly simple questions. And once again, I find myself filling that particular role. So without further ado, I think we're going to start talking about pictures, if you don't mind. So let me just click something. Yeah, for the delegates on, all delegates except the panel are muted. If you want to ask a question, there is a chat function. It sounds like someone's just been to the loo, actually. There is a chat function. What on earth is that? There is a chat function at the bottom there, and you can click there and type something, and I might pick it up and ask the panelists if it's relevant. Okay, so we're going to talk about perforated eardrums first of all. So panel, Susan, 5-year-old child who might have had a grommet at some stage when it was younger, now is fit and well but getting ear infections, and they've got a nice perforation of the left eardrum. Other ear is normal, and the hearing is, you know, pretty much normal. So how would you manage this one?
So I think I mean, he's a 5-year-old, still quite small to consider surgery, I think. So I would be asking him to keep the ear dry, I prescribe a swim plug, so it's custom made, so that makes it easier. And if they do get infections, then I tend to use ciprofloxacin and dexamethasone drops, because that's safe with a perforation.
Yeah.
And then wait it out, because most likely it will heal on its own. If it doesn't, then consider myringoplasty.
How likely is that to heal, do you think?
I find it varies. I mean, because quite often it's not uncommon to get a perforation after a grommet, so a fair few of them will heal. Clearly, the bigger the perforation, then the more of a difficulty that would be, but it's still quite small. I think there's a good chance it will heal.
Okay. So one of my colleagues, Dan, doesn't really seem to have an age limit on mending perforations. Does anybody else in the panel draw a line at a specific age? Adrian, for example?
Not really. The question is how much trouble is the perforation causing, and if it's not causing any trouble, then there's no rush to repair it. And I think there is a possibility that over the age of 5 or over the age of 7, or perhaps waiting to the age of 10, that middle ear function has a better chance of being normal. Always used to wait till the age of about 10, until the mesh analysis from Birmingham, which said age didn't make any difference and the status of the contralateral ear was more important. But of course, that itself is dependent on age to some extent. So if there's no rush, if there's no indication, you don't have to repair a hole just because it's there. I would, like Susan said, I would wait on this one.
Okay, Will, say that this child was getting a lot of infections. What would you do about it then? You know, their parents were kind of leaning on you to do something.
So I think generally, if you have a dry perforation, it's very reasonable to wait. And my practice is wait till about 10.
Oh, okay.
And looking at also at the other ear. So if the other ear is glue free, and it's not having problems, then that's a positive factor. The other aspect is that if you wait till 10, you have a child who can actually help you. They will lie still to have their packing taken out. You don't have to go back to theatre to actually remove all you put in. But if the situation is changing, the other ear becomes more pertinent, because at 5, if they've got a completely glue-free other ear and no acute otitis media on a regular basis, then you can start to think about it. If they've got either glue or recurrent AOM in the other side, then if you graft this, they may well get glue back, or they'll reperforate. And so sometimes you've got to tough it out. However, if the other ear is disease-free, it's looking good, they're getting lots of infections in this ear, then you start to think, shall I do something?
Okay.
Now, the worry I would have with this ear is the myringitis. If you look at that ear carefully, you've got a myringitic area. You can see posteriorly between the perforation and the tympanosclerosis, it's not normal drum, it's myringitic drum. And sometimes with these post grommets in perforations, you get the middle mucosa either invading or not, or the epithelium not healing, and you get this big myringitic segment. And if you look at it, you can see there's a circle of myringitis asymmetrically more posteriorly. And if you don't take that off, they will actually heal with myringitis, and then you'll have one of these nasty perforations, these intact drums, but with a myringitic segment.
Okay.
So I would be looking to treat this heavily to see if I could change that myringitis. If that myringitis doesn't change, then you're looking at really taking off possibly 50% of the drum to actually get fresh edges. And of course, the bigger hole you have, it is possible it won't heal so well. So I would be wary of this ear in terms of surgery, and I would want to get as good as I could before I operated.
Okay.
I suppose, Mike, I suppose one exception to the rule, we probably all have a number of children who've constant, frequent otorrhea, tympanosclerosis of the drum, and then very suddenly on a waiting list for a long time, they get tympanosclerosis of the chain and they get this dramatic conductive hearing loss.
Okay.
So with long waiting lists and that sort of thing, you just want to be mindful you don't leave a child running every month and not without the surgeon knowing about it, or that's the sort of one you might want to do urgently and not leave for years.
Keith, say that you decided to bite the bullet and, you know, you've treated it with some topical steroids and it's looking less myringitic. The other ear is virgin, perfect hearing, and the parents are desperate for an operation. If you decided to bite the bullet, what surgical approach would you take to that?
It'd be very suitable for a little transcanal butterfly graft, a little cartilage graft.
Do you do lots of those?
That's what I would do. That'd be my first technique. As long as you're not butting on, if you're right on the umbo, it's sometimes a little, doesn't sit very nicely.
Okay.
But as long as it doesn't turn into a huge perforation once you freshen the edges.
Yeah, quite. Okay, excellent. I'll move on. So we've already covered that. What's the youngest age? Keith, do you have a sort of youngest age for myringoplasty? Or?
Yeah, when I was, my registrar interview was age 10, where it was what the paper said years ago. And now it depends how symptomatic the child is.
Yeah.
So it was my lowest. We've had a couple of 2 or 3 year olds with MBL deficiency, syndromic chronic immunodeficiency. We've tried everything and we just can't get the ear to settle, and we bite the bullet and it usually works.
Go for it. Okay, excellent.
I just got sorry, Mike.
Yeah, Susan.
We talked about laryngitis. What's the panel's, do we have tips on how to treat the laryngitis?
Yeah, well, you brought it up.
I would have to say, laryngitis is the thing I find most difficult to notice, because it's often not of your making. Sometimes it is of your making, and to actually try and settle it down is really difficult. So I would have to say, for me, it's the biggest problem I face post-operatively, because usually the drum will heal. You usually get a healed drum, but if laryngitis starts, you have this healed drum with this wet segment, and they always, every time they get a cold, they get a little bit of wetness in their ear, and they get a bit of irritation. So what do? I try a course of Silodex drops, then I will give them Betnazole for another 2 weeks after that to try and see if you can get any improvement. I'll then put on trialcotyl ointment, and I'll try and cover it and leave it like that. If it's still not working, I'll use a defocused KTP laser, and I'll try and burn off the laryngetic segment, leaving the intermediate or inner layer to see if you can get rehealing with squamous epithelium, although the risk is actually sometimes the drum breaks down when you do that. And then the other option is to go back in and excise the entire laryngetic area, but the trouble is you can get laryngitis coming back. So I would love to have a good cure for laryngitis.
Okay. Yes, it's my experience that I mean, I'm not an otologist, but I give them steroid drops and it sort of gets a bit better, then it seems to come back again. Quite awkward. Right, let's move along a little bit.
Mike, there was a question actually from somebody about operating on a discharging ear that's not responding to treatment.
Okay.
You want to take that now, or
yes, let's take it now. So I'm going to go forwards a little bit. Infected one that's discharging. So what are you going to do here then, Adrian? Why do you start?
So I would use drops in much the same way that Susan had said to use we have ciprofloxacin dexamethasone drops here to try and calm it down. My preference, there is when you mentioned that, Susan, it made me think of work which has been done in a couple of centres in the US, showing that anytime you apply Ciprodex drops to the ear, there's a risk that you're more likely to have a perforation afterwards. It's been shown if you put the drops in at the time of grommet insertion, you're more likely to have a perforation when the grommets come out. And animal model studies show that the drum doesn't heal so well with ciprofloxacin or dexamethasone, or even worse, a combination of both. We sort of looked at that question ourselves retrospectively, and it doesn't seem to make much difference, but I think it's something to be mindful of, that maybe that combination of drugs isn't good for healing of the eardrum. But in the absence of anything better, that's still what I would use at the moment. And so I would try and get it to settle down, but if it didn't, as the question implies, I would still go ahead anyway. And interestingly, that meta-analysis that I referred to from Chris Colston and colleagues in Birmingham showed that, and I think there was another review as well, showed that the success of repair in an actively inflamed ear is better than in a dry ear. So although it's a bit of a pain having to operate on an ear like this because it bleeds and you can't see so well, I'm not sure that it's a reason to avoid surgery. In fact, it may be the indication for surgery.
Okay, right. Susan, what do you think?
Yes, I would. I wouldn't. I mean, I would do the same. I wouldn't operate if the patient comes in. So certainly I'd try the drops to see if I could settle the infection before, but I wouldn't delay surgery if there were. The problem is if you've got a patient who has multiple infections and repeated infections, then often surgery is hopefully the solution to the problem. And I think you just have to warn them about that. I mean, I think I'm a little bit more cautious if they have an overall infection, if they're febrile or they have something else going on, as opposed to an active discharge where the patient's fine. Treat it as best as possible. I think there is some, we used to have this idea of, well, do they need to have a cortical as well? But
right, I was just about to mention that.
For ages. Yeah.
So that's sort of doing a CT and doing a cortical isn't something that you'd necessarily worry about so much now. I know
doesn't
Okay.
seem to be.
I think there's very good evidence that doing a cortical mastoidectomy adds absolutely nothing to the chances of successful outcomes. So I would definitely not do a cortical in this.
Anybody else, Keith or Will? Do either of you consider a cortical, or is that old hat now?
Not routinely.
No,
I would consider an adenoid. Sorry to butt in, Will. You carry on.
no, I was saying no. I wouldn't do one routinely. I mean, if you look at this picture, the middle ear is actually quite quiescent.
Yeah.
And actually, this is again a more meningitic. So I wouldn't operate on an infected perforation. If there was mucopus around, I wouldn't. If there was a moist ear and so there was inflammation, I would. And so I would draw that difference. If you've got mucopus in the ear.
Mike wanted us to be provocative, so I'm just going to try and stir it up a bit. So your kid arrives on whatever day your operating list is. You have a look in the ear and it's pussy. You're going to cancel them and bring them back on another day.
So what I do,
carry on.
So with perforations, I see them between 1 and 2 weeks beforehand because I don't want to cancel them on the day. So I'll see them. If they've got a pussy ear, I will treat them with drops. And when they come back, usually they don't have a pussy ear, but they might have a moist ear. And so I don't like mucopus, but I'm very happy with slightly stained mucus.
Okay.
If they arrive, if I haven't seen them and they arrive on the day and they've got an active pussy ear, I'll send them home.
Okay. Good. So let's talk about another picture. Adrian, sorry.
Word, sorry. I just wanted to throw in the word adenoidectomy because I think, if we're talking about young children and in discharging ears, it's important to consider that may be contributing to the problem.
Absolutely.
Okay. If they're enlarged or just regardless of whether they're enlarged or not?
Well, I don't know.
Okay.
Really, but, yeah.
Okay, let's move on. Here's another perforation that 8-year-old, the hearing in the other ear is okay. They've got a very marginal conductive loss in this side. Once again, they're getting infected, and you've decided to bite the bullet and operate. Well, I would have done, let's say, but of course I could be proved wrong. Susan, what surgical approach for that one?
So to be fair, it's a small. Relatively small perforation. So you've got a few options. You could do it you could certainly do it endoscopically with permeatally and use tragal perichondrium or tragal cartilage to help to reinforce that. You could make a small endoral incision or a small postoral and repair it. So I don't tend to use a cartilage button. I tend to use grafts and I tend to use cartilage as well. But I think this would be a fair one to do endoscopically. It's small enough.
If you were doing that one, let's say you were doing it endorally or postorally, would you use cartilage routinely to reinforce the repair?
So I tend to use cartilage. I make it quite thin, but I tend to use cartilage.
Yeah.
In my hands, it gives better results than just using fascia.
Okay. I know which way you'd repair this, Adrian. I suspect you'd use the endoscope. Keith, what would you do?
Yeah, I like Adrian's way of doing it. I'd probably still use the microscope at the moment. It'd be tempting to try to freshen and to push through underlay fascia graft, but because it always seems like such a lot of work to lift the posterior flap, flip the eardrum over, and then unpack under that. But
so a push through is where you get a bit of tragal perichondrium or temporalis. You put gel foam into the middle ear, and then you just squeeze the graft through the hole and arrange it neatly.
You can stack it on gel foam. Sometimes you can hold it with surface tension and a little epidisc laterally.
And that works okay for you?
Well, no, you have some failures with them. It's a hard. It certainly is a tempting one to try, but there's always a risk it'll fall away with all that space down towards the eustachian tube there.
Yeah, but I suppose a bit like the the butterfly graft, you're not doing much to the middle ear space, are you? You're not lifting it.
It's tempting, but all of the manubrium of the malleus there it sits against the graft, so I find it not so helpful to try and snap the graft in.
Okay, Will, what would you do with this?
So this is a 30-degree endoscopic view, and you're looking around the corner, and so if you look straight down the canal, they'll have an anterior bulge, which will actually obscure probably most of your drum as you look down. it's a big perforation. Once you've taken the edges off, if you're going to take a decent edge off, you've got about a 40% perforation. And if you look, it's quite near the anterior annulus. And so you're going to be taking you're going to be getting very close to the anterior annulus. And so therefore, for any push through, you're not going to have the support. So I would do this, for me, would be a post-auricular. I'd open it up. I'd elevate the annulus probably almost 360 degrees. So I'd go around over the top of the attic. I'd elevate the anterior annulus from at least down to about 4 or 5 o'clock. And then I'll do a underlay temporalis fascia onto the bony annulus going under that way. And so you get good support. The anterior ones, the ones that fail. You want to do them well. You want to give them good support. I don't tend to use that much cartilage. I think cartilage is bulky. I think cartilage also doesn't give you the flexibility, because this is going right up to the malleus. And so therefore with cartilage, you get this angulation under the malleus, because you could have abut the malleus. And actually with temporalis fascia, you don't. You could also actually take on these ones where they're really right up close to the malleus, you can actually take the tympanic membrane off the malleus handle down to the umbo, leaving it on the umbo, and then you can actually go between the TM and the malleus to give you support that way. That's the other way of doing it. So I would post-auricular. This one's difficult. It's anterior. There's some tympanosclerosis in the drum. The drum's going to be a little bit more stiff. You're going to have to, if you don't do it carefully and properly with good support, you're going to get a high failure rate in this kind of tympanic membrane.
So there's quite a range of opinions on that one. That's good.
I asked Will a question, because I agree with everything you said, Will, actually, except that I would do this endoscopically without any doubt. But I didn't quite catch, you said you'd raise the flap to about 4 or 5 o'clock where you elevate the annulus. Do you mean you'd start at the top in the pars flaccida and peel the annulus downwards, down towards the forameatus?
So what I do with these kind of things is I'll do a classic 6 to 12 incision posteriorly.
On the posterior wall, yeah.
On the posterior wall. And then I'll actually come up over the annulus underneath the meatal skin. So I can't show you with my hand, but I'd like to. You go up and over, and you go round. And so what you do is, leaving the anterior tympanic, the skin intact, you actually elevate the annular ligament out, and so you then put the graft under, and you tuck it between the skin, the epithelium, and the bony annulus, and so you've got support. So fundamentally, the graft will be on bone 360 degrees.
Okay, so that's exactly the same. You said, I didn't quite catch, because you said you'd elevate the flap to 4 or 5 o'clock, but I guess that's the posterior meatal skin. You
correct, exactly.
Skin. Right, okay, but the annulus, okay. So I would do exactly the same thing endoscopically, in fact, and then the graft goes underneath the malleus handle.
Correct, and so you've actually got graft onto bony annulus 360 degrees. So you get no fallback, and you've got definite support.
Yeah, no, that's exactly the same as I would do. Yeah.
Okay. I'm going to probably just put one more or so up. Let's have a look. Yes, I quite like someone to talk about this stuff. This is what I've always been told is snail tracking. And actually this child's got a nice neat hole on one side, and they've got that on the other side. And the conductive loss is the one on which the snail tracking is. Can you see that, everybody? Will, can you see that?
Yep.
Yeah, great. So starting with Keith, that's the one ear, that's the other ear, and that's the audiogram. Do you worry about the snail tracking stuff? Do you think
it tells you there's a little perforation there trying to heal, but unsuccessfully. So you get this migration laterally along the canal wall.
Okay.
Now it's hard to say if it's just a small perforation. There's quite a hearing loss on the left ear, I think.
Yeah, there is. It's bizarre, isn't it? Yeah. It looks like it should be the other way around, but I did check it.
Yeah, so you're not so sure. That could be, you need to lift that off, make sure there's not a little sac underneath. Look at the status of the IS joint.
Okay.
Yeah.
Yeah, that's fair enough. let's just talk about one more. So here is someone who's had a laryngoplasty before, maybe a year or two ago, and they come back and they've got intermittent discharge. They've got this tiny little hole here. Susan, what would you do about that?
So it's difficult, isn't it? Because it's tiny, but there's clearly a lot of scarring of the drum. A mild hearing loss. I mean, I think I'd be tempted to wait to see if it will settle on its own because it's so small. I mean, if you're going to treat, then one option is you freshen the edges and put in a bit of gel foam, just see if that will encourage it to heal.
Mm-hmm. Is anyone still doing fat plugs for things like this, or is that very old-fashioned?
I don't tend to use fat plugs.
No, okay. Yeah.
I don't know if the other guys do.
Adrian?
I don't, but there's a guy in Montreal, Sam Saliba, who's published very good results in the laryngoscope from using a fat plug with an epidisc over the top. But I don't know, does this ear need fixing at all if it's asymptomatic? I don't think it's going to change the hearing if you close that little hole.
Well, of course.
If, for example, this was a kid with a cleft palate and a retraction on the other side, I'd be delighted to get this result because that little hole will equalize middle ear pressure, probably in a fairly asymptomatic way. So it does depend on the kid's situation, really, whether you want to do anything about it or not.
Yeah, let's say it's getting a bit infected. Would you, every 2 months they're getting discharged from that ear?
Yeah, it's difficult because obviously all my perforations close after.
Yeah. It's an academic question for you. Yeah, okay.
Yeah, no, it's difficult. I don't know. I don't know what I'd do. Maybe I would. Goodness knows. Maybe. Yeah. I mean, as Will said, once you have to make your decision about what you're going to do after you freshen the edge, because you might find that when you kind of cut this up a bit, all the scar tissue comes away, and you've got a much bigger hole than you thought.
Yeah. Okay.
I might do a cartilage butterfly graft for a little hole like that if it looked like it would pop in well, but.
I mean, there isn't a right answer for this. It's not like I did something clever and I'm going to present you with a beautiful eardrum, because that's not the case. I think I sat on this for a bit and just took the one photo. Well, what would you say about this?
So the question I would ask is, did this work, and then has it reperforated? Because sometimes you see these ears which fundamentally the perforation is part of a sort of a long-term process, and is almost nature's grommet, and you close it and then it goes pop and you get a little perforation back. So it could be, if one's generous, that you've reperforated. The other aspect is it could be an aspect it hasn't healed. So I would want to know, did it heal then reperforate, or has it just not healed? If it's just not healed, if it's reperforated, then the trouble is if you try and do something, you're going to get a problem in another place. It might be one of these patients who do get recurrent acute otitis media. If it's not healed, if it's causing problems, I would probably endoscopically or microscopically try and freshen the edges, and I would either use cartilage or fat.
Okay, right. I'm going to I'm going to stop my bit of the presentation now because actually time is already whizzing past. So, would you like to start your bit of it, or from your computer or mine?
How do I do it from mine? You
could share if you've got it open in PowerPoint. You can press the green button.
Hold on, no.
I've got to end screen share.
No, don't worry. Mike, can I just say move on?
Yeah, please.
Okay.
Do.
So, I'll try and make this brief. So, I would think of what's going on there as chronic otitis media, where your ears been inflamed from some form of infective insult, and it's trying to heal, and it's a battle between the two. And so a perforation is not just a defect, it's a sign that battle occurred. Next one.
Give me a second. There you go. Right, I'll stay on it.
So I think we used to talk about tubotympanic, CSOM, self and unsafe, and I think we ought to change to COM with cholesteatoma and without. And without, we often call it mucosal. Next one. And it can be active, it's got discharge, inactive, you've still got the pathology, it's dry, it's healed. And the next picture shows you, and this is a classic, healed COM. So you can see the tympanosclerosis, the thin drum. This is the end product. Next one. So tympanic membrane retractions. Next one. So what's going on? So due to the inflammation, you've lost the middle fibrous layer, so therefore you have a thin eardrum. And with children, if you've got ET dysfunction and negative middle ear pressure, you then get this thin segment starts to retract. And it can be anywhere, but classically posterior and superior. It can stick to the ossicles, and then if it sticks, it can start to erode or collect debris to form cholesteatoma. Next. And so this is simple atrophy. So on the left, you can see a drum which looks normal, but when the child valsalvas, it bulges out. So they've got over their eustachian tube dysfunction, and therefore it doesn't retract, but it's still there. Next one. So prevalence varies in certain populations. Navajos quite small, more in the Danish. But interestingly enough, if you've got glue ear, quite a lot develop retractions over time, and some can be advanced. Next. So the big question is, if you've got a retraction in a child, which ones are going to progress? And how do we answer that question? And it's quite hard, I think. Carry on. So for the registrars, you need to know the two classifications, TOS and SARDE of attic and pars tensor. You probably know them already, just to run through them for the registrars. Carry on. So TOS describes attic retractions. There's a mild where it's just beginning to pull back in. If it touches the malleus neck, it's stage 2. If it's causing some erosion of the bone at the top of the ear, it's 3. If you can see malleus and incus head, then it's 4. Carry on. So this is, you look at this and you can see there's an attic retraction. You can probably see the head of the malleus, possibly something more. That's probably stage 4, but in a crying, wriggling child, it's quite difficult. Carry on. So attic retractions, sort of prevalence in children between 5 and 10. Most are small, but you do get 1 or 2% which are quite deep. Carry on. So SARDE. Now, SARDE classification of the pars tensor, there are some issues with it, because he talks about grade 1 being mild retraction, grade 2 touching the incus of stapes, grade 3 onto the promontory, but it comes off if you suck it or with a valsalva. Grade 4 is adherent. But the trouble is, a lot of retractions go to multiple areas. So what I will do clinically is I will write what SARDE grade it is, but also I will draw it and document that. Next. So in terms of SARDE, grade 1 doesn't tend to progress. Grade 2 can come and go, but about 16% may worsen. Grade 4, often they worsen, but still 16%, and 10% may go towards cholesteatoma. So next one. So what we're looking at is, if you look at the more significant retractions, roughly about 10 to 15% will progress to cholesteatoma. However, by the corollary, 85 to 90% will either stabilize or improve in children. And we see these in terms of adults. You see adults, and you look at their ears, and they've got a stable pocket that's been for years. So the question is, which do need surgery? Which of those small groups need surgery? How do we choose? Carry on. So what options have we got? We can either manage it conservatively. Now, I've always liked the term MICLO, masterly inactivity with cat-like observation, and also do their hearing. Or we can operate either on the drum, or, as Adrian suggested, on the adenoids if you have a child who's got eustachian tube dysfunction. Carry on. So what surgery are you going to do? If it's in the attic, you could try and ventilate it, but that doesn't often work too well. If you're going to do something, you're probably going to actually have to expose the pocket and reconstruct it in one of the surgical ways. Next one. In the pars tensor, these often will actually respond to ventilation. So you can either ventilate, you can, if the pocket's mobile, excise it and ventilate. You can excise it and reinforce it, or do something bigger. Next one. So, which pockets need surgery? Well, I think about my clinical practice, and what do I decide on? Is it attic or is it pars tensor? What stage? What's the age of the child? If they're younger, it might improve with eustachian tube function improving. If they're older, this might be more permanent. What does the contralateral ear look like? What's their hearing like? Does it discharge? And does it progress? Carry on. And so really, we're all trying to weigh up what to do. And we want to know what's the potential for progression, which ones we should operate on, but also the risks of surgery. Although I'm sure in your hands, Adrian or Mike, you never have problems. However, occasionally you do, and occasionally it doesn't work quite as well as you hope. And if 85% are going to be fine, well, you've got to weigh that up. So it's hard and fast rules are difficult. Carry on. So what grade? Retracting back looks to me like a grade 1. Next one. So now it's touching the incus, but also you've got glue. So is that 2, or does glue put into a different grade? So probably grade 2. So next one. What I would do generally for these is grade 1 or 2, good hearing, no activity, normal ear, probably watch. If it stays stable, continue watching. If they've got glue ear, consider a grommet. Next one. So here, tympanic sclerosis, we're just touching the incus, maybe a bit of incus erosion. Next slide. Here, you can just see it touching possibly the promontory, but anteriorly you've got a bit of a retraction as well. Is that a bit of keratin building up? Next slide. So grade 2 or 3. If they've got good hearing, if they're not active, again, I'd watch, but if it's progressing or not improving, think about excising and ventilating. Next one. Now here, we've got a grade 3. It's touching the promontory, but more importantly, you can just see it starting to erode the long process of the incus. So maybe the hearing's going off. Next slide. So hearing's going off, grade 3, I would certainly do something about it. I'd elevate it, I'd possibly reinforce it, or ventilate it. Next one.
Well, just a query about that.
Yeah.
Mike, would you just go back one, please, to the photograph? So if you excise that area that's retracted, particularly where it might be adherent to the saccular chain,
yep,
are you concerned about having bits of drum left behind?
Absolutely. And so I would want to see, if it comes off nicely, I'm happy. If it sticks, I'll use the laser and I'll fry to make sure there's nothing left in there. If I'm not certain, I will reconstruct and second look.
Okay, would you do a DWI MRI?
I don't think they work well enough because I'm not expecting to leave a huge amount. And I'd much rather go back in. Also, when you take this off, it is possible their hearing will get worse because they've got a fibrous connection. And so what I'd want to do is, if their hearing was poor, if they've got about, it might be they're dropping off to 30, 40 decibels, I'd elevate, and then if they've got some LPI left, I'd probably put on some Cerana cement if it had gone entirely. So I would reconstruct either at the time, if I was very happy I got it clear, or I'd reconstruct and I'd come back if the hearing wasn't good.
Okay, and do you wait about a year for that?
Yeah.
Okay.
Okay. I know you seem to be quite keen on the KTP laser. Well, would that be fair to say?
I think it's great for otological use.
Yeah. Okay.
Works
yeah.
Well.
Where are we? Here we are.
So that's the kind of result you want. So nicely reconstructed. If they've got good hearing and I'm happy it's out, watch it. If actually I've worried I've left something or the hearing's poor, I'll go back in at a year.
Okay.
Next one, Mike.
Yep.
So grade 4, touching the promontory, looks adherent, but also you can see it beginning to go around the ossicles as well. And so the grade 4 doesn't describe it so well. You need to actually write down what you see. Next one. So it all depends, for me, it all depends on the hearing at this point and whether it's inactive or active, because you see adult ears like this, if they just remain stable and they've got good hearing. So I'd probably still watch. If it's stable, I might continue to watch. If it's progressing or not improving, then I might well do something.
Okay.
Next one. And then you get progression. On the left side, you can see that snail trail of keratin just beginning to not come out of the hypotympanum. And on the right side, you've got activity. Next one. And so with this one, I think you want to do something. You want to get in there. It's progressing. And what you don't want, next slide, is you've waited too long, and there you can see the cholesteatoma building up, and you've eroded LPI. So it's very difficult, because ideally you see these regularly, you photograph them, and you look for progression. But we work in a system in the NHS where you ask them to come back at 2 or 3 months, and you see them a year later. And so I haven't got an answer for that. And so Mike, next I've got a few ones that to go out to panel.
Okay, Will, I'm not going to offer an opinion other than refer to an otology colleague. So just ask the other three, if that's all right.
So what do you think of this? What do you think is going on? And can you give it a grade? And what would you do?
Who's going to start? Should we go in order? Susan?
So in terms of a grade, part of it's on the promontory. It looks adherent, so potentially a 4. I think I'd be concerned about. You've got this bit of wax over the long process of incus and stapes, so really you need to take that out to see what's going on.
So Mike, go on to the next slide. So I don't think it's wax, I think it's keratin. It's keratin. It's almost like a keratinous horn building up over what is likely to be the area we see now. So I've now removed that under the microscope.
Right. Okay. So I would be thinking that that's unlikely, because it looks like keratin. It looks like it's adherent. You know, I'd be having that discussion with the family depending on the age of the child. If you really wanted to try conservative, then you could examine under the microscope, put in a grommet and see if it elevates. But I think it's unlikely to do that because of the extent of the retraction, in which case I need to excise it and reinforce it with cartilage, is what I'm thinking.
Okay. Keith?
Yeah. It looks surgical right from the start. It looks like a tympanoplasty here. Hearing test, CT, maybe a CT scan. Depends if they've had a lot of pain, how long this has gone on for. Check and see how deep that attic retraction is superiorly. But yeah, discussion with the family about actively intervening rather than continuing to watch for a long period of time, and a tympanoplasty procedure.
Okay, Adrian, open or endoscopic?
Oh, I would do it, and if I was going to do anything surgically, I would do it endoscopically without any doubt. The question really is whether I would do anything surgical at all. The problem with all these retraction cases, if you put in a grommet, the grommet's going to fall out, and then either the physiology will have improved and the kid will be okay, which would have happened whether you put the grommet in or not, or the physiology hasn't improved and you're back where you started. And often when these ears have had several sets of grommets, they don't last very long. So you might be putting a grommet in, once or twice a year for years, and never really change the outcome. So I wouldn't put a grommet in. The problem, as people have alluded to, the problem with doing a cartilage tympanoplasty here is you might make the hearing worse. That happens. I looked at my data and it was about, I can't really remember, about 1 in 20 or 30, the hearing got worse. And occasionally, as people have alluded to, there will be the risk of skin getting trapped, and so you then get you've caused a cholesteatoma when they didn't have one in the first place. I would have cleaned. Most kids would have, I think it's fair to say, would allow you to clean off that keratin in the clinic, and if there's no granular, sorry,
I said maybe they would in Toronto.
Yeah,
I'm not sure about Bristol.
It depends a bit on the kid, doesn't it? But
yeah.
If they wouldn't, then I would get them to put oil drops in to soften it up. And sometimes you find when they come back, that the keratin has migrated spontaneously. And I think in the old days, I would have done a cartilage tympanoplasty on this ear. But these days, I don't think I would. I would just monitor it. And if keratin begins to accumulate in the tympanic isthmus, either anteriorly or posteriorly there, that is not cleanable, then I would operate. I think the aim for me is to save the stapes more than saving the incus, really.
Right.
That's how I approach the cleft palate population as well. Wait and wait and wait until the keratin is gathering and not clearing. Because if you go in and reinforce, even if you leave a millimeter gap around your cartilage, it invariably retracts.
I think that's the problem. I agree, Keith. Yeah, yeah. You do get some great results from a cartilage tympanoplasty in this kind of ear, but I just have a feeling those are the ones that would have been okay if you'd done nothing. So it would have been stable. I don't know. I don't know the answer, and I think you said this well, that it's difficult. You also, another thing that's important actually that we haven't really emphasised is the preference of the parent. You're going to get informed consent. Are they the kind of parents that want to do anything to try and preserve the hearing and really want surgery, or are they the kind of parent that's terrified of having surgery and really wants to try and hope that it will get better without doing anything? That for me ends up really being the deciding factor, is parental preference.
Okay. Will, should we do another one?
So there's a question on the chat, Mike.
Yeah, I would. Oh, there was a question on the chat. Yes, is there a place for otovent in the management of retractions? Will.
I'm unsure whether otovent truly works. However, it's a way of keeping the parent and child occupied while you're waiting. And so by all means, I would normally say, fine, we're going to wait. Why don't you try this otovent device? Whether it truly works, I don't know. I'm not sure.
Okay. Susan, do you use it?
I don't tend to.
No, I tend not.
What about eustachian tube dilation, Adrian, with your North American colleagues?
I am not an enthusiast, and I'm quite skeptical about the potential for improvement in this kind of scenario. And I have spoken to a lot of people every time I get the opportunity, really, and I don't get the feeling that it has been beneficial in ears with tympanic membrane retraction. Obviously, Dennis Poe's study shows that it makes middle ear pressure a bit better for a while afterwards in adults, but I don't have any enthusiasm for doing this in children that might grow out of their disease. And you can calculate a number needed to treat. If it was sort of 50% effective, and 10% of these cases are going to turn into cholesteatoma, then you're going to have to do. I can't do maths and talk at the same time, but you're going to have to do a lot of cases before you get one successful benefit. So it's pushed very hard, perhaps there's too much economic pressure in the equation to really figure out the place of it.
Surely not.
Yeah. Right. But it would be great if it does work. So we have to, remain a little bit open-minded about it. I think it should be done. I think, it should really only be done in properly controlled trials. But you probably need 5-year follow-up on every patient to really figure out whether it did anything or not.
Yeah.
Okay. Can I just ask, Adrian, you said that you'd observe it, but if you're going to operate, you'd do it endoscopically.
Yes.
I'm presuming you'd still do a cartilage tympanoplasty.
I would, definitely, yes. Yeah, with the tragus, yeah.
Okay.
Right, Will, should we do another one?
Okay, next one.
Where have we got? There we go.
So, I mean, this is quite similar, isn't it? So let's go on to the next one. Okay, what about this?
All right, Adrian, you start this time.
Oh dear, okay, well, that's a pity because I was going to wait and see what everybody else said. I'm wondering why you're showing this picture. And sometimes when you look at these things more carefully, you can kind of see through the drum and see the edge of the, but the problem that we have here is that you can't see the limits of the retraction pocket. It looks like I don't know if that's the tip of the incus or the capitulum of the stapes that we can see through the defect. But apart from, you can't see the sidewall of the pocket anywhere. Sometimes when you look a bit harder, you can actually see the limits of the pocket underneath the eardrum. But I can't really see that. So that makes me guess that maybe it doesn't go too far anteriorly. There's no keratin buildup, the snail track thing around the edge of the pocket, which makes me think that it's probably self-cleaning. I mean, of course, what we would do is we'd take a history and we'd examine the other ear as well, and we get an audiogram and all that kind of thing. But I don't know, in terms of what I would just do for that one on its own, I rarely, actually, as a rule of thumb, I rarely book surgery the first time I see a retraction pocket, unless it's actually a cholesteatoma. Normally I would, you know, clean them up, talk about stuff, and then see them again a few months later just to see if it got worse or better. But I'm interested to hear what other people say and see what happened to this kid. It's an unusual appearance, really.
Okay, Keith, what would you do here?
Yeah, it's an unusual appearance, but it might be stable. It might stay like that for decades. So it depends on the age of the child, as Adrian says, all the other factors. So I would be watching that for the first few visits, photo documentation, showing it to the family. And if there's any sign of skin gathering or, you know, you have to do something about it.
Susan?
I agree. I think I do find the photo documentation in clinic is quite helpful because it's a reference point, particularly if as in the NHS, you're not always the person seeing the patient. So it becomes much more obvious if the problem is getting worse. I might have tried a grommet until Adrian said he doesn't think it works at all. But clearly, that sense of, well, can I improve middle ear ventilation? But I think it just depends if they, you know, if they had any history of a smelly discharge or if the hearing goes down, then I'd be thinking, do I need to investigate further? Do I need to do a scan? Yeah.
Okay, good. Will, anything else to add to that, Will?
So no, I'd agree with most of that. I mean, interestingly enough, if you look at the pocket carefully, you can inferiorly you can see some bubbles of glue.
Yeah.
And so this is a child who's got glue ear, and so I actually put a grommet in this one because I always think if you can see glue, that means they have definitely got something going on in their middle ear space. And this is one of these strange ones, and this is why I think the SARDE classification really has limitations, and you really have to describe or photo. And so I actually anterior myringotomy, lots of fluid, and with a sucker, I was able to peel and pull this off, so it came out like a sock. And then I had that big question: do you cut the suck off, or do you actually just put the grommet in and hope the drum will refashion? And the answer is I can't remember what I did, because this is some years ago. But usually with this kind of deep retraction, if it comes out, and sometimes they do, I'm always surprised. I'm always surprised how sometimes you release the pressure and you actually get the sock coming out. And I usually cut the sock off, because I think that when you've got so much floppy tissue, you actually want to. I prefer perforation than a very deep retraction.
Yeah, I agree with that for sure. I've only done that once, and then shortly after it retracted and became a cholesteatoma. And I spoke to John Hamilton about this because his predecessor, Philip Robinson, used to do that procedure of amputating retraction pockets and was quite happy with the results. But John got to see the long-term outcome, which was of re-retraction, and perhaps not surprisingly, because you've replaced if it does heal over, it's going to be a relatively atrophic layer with no middle fibrous layer, so it's not very strong, and so it's not really surprised that it would retract again. But that's about that, Will?
So that's why you've got to put the grommet in as well.
Yeah, but then what would you do when the grommet comes out? Because that's only a 6 month temporizing.
It would all depend upon the age of the child, because if they were still within the glue ear phase, I would grommet them or T-tube them. I don't tend to do that many T-tubes. I'll put in 3 grommets before a T-tube. But I would try and see them through their eustachian tube function phase.
Yeah, I think that's a fair point. And I think the problem that I have with my practice is that often it's the people who've had lots of sets of grommets that are sent to me what to do next. And the reason they're sent to me is because the parents have got disillusioned with the management they've had with their other secondary, in secondary care, and so I only see one end of the spectrum, perhaps. And I can imagine that there probably aren't, like you say, a lot of younger kids that would benefit from a tube as a temporizing measure, stop things getting worse while we wait for them to grow out of their problems. So I probably don't see that the benefits the way that you do, I guess.
I suppose my view has always been I'd much rather repair a perforation than actually a deep adherent retraction going to cholesteatoma. So for me, I will have a conversation with the parents about perforation good, retraction bad.
Yeah.
Fair enough. Should we go on?
Yep.
That one?
Yes. Okay. So what do people think of this one?
Susan.
Very unhappy ear. Yeah, so it looks like there's glue, which you can see sort of posterior inferiorly, but there's a fair degree of attic retraction as well. So I'd be thinking, is there cholesteatoma in this? Is there some cholesteatoma that you're not seeing? And just that anterior portion almost looks as if there's some white substance behind the drum as well. But that might just be the reflection. So I think it depends on the symptoms. If it's, you know, if it looks like it's just hearing loss and there's glue, then we might try a grommet. But I think if they're having a smelly discharge as well, I'd want to CT them, see what their hearing's like, see if there's anything more that I'm not seeing just by looking at the drum.
Okay. Keith?
Yeah, history, audiogram, and CT scan based on that irregular whitish mass and an anterior segment.
Yeah.
Because of course, just the tiny little mouth in the attic doesn't tell you anything about the extent of the sac, of course. So it can be quite extensive.
Adrian?
Yeah, so when I look at this, I'm not worried about the mesotympanum. I think the bulge, you can see the bulge from the tensor tympani muscle canal, I think, just above the eustachian tube orifice. And I think that the other white stuff in the anteroinferior quadrant is probably just the promontory, would be my interpretation of how I see this picture, and with a bit of meningeal sclerosis posteriorly. So I think in the middle ear, there's just an effusion, and that might benefit from having a tube put in. But what worries me is the pars flaccida retraction, because there is that little bit of keratin building up around the edge of it. And I think this is a really difficult question, is how do you know when cholesteatoma has developed in the depths of a deep pars flaccida retraction? And the problem is, if you do a CT scan on this kid, well, I know that you're going to see opacity in the mastoid because there's opacity in the middle ear. And so the scan won't help unless there's a massive amount of bone erosion, which if we've been following this kid, you know, maybe there won't be. The CT scan isn't really going to help you. You could put a tube in first so that the middle ear is ventilated and then do the scan. But even so, if that's a big attic pocket, then you know, you might not get ventilation in the antrum. So you don't really know if this is a cholesteatoma or not. And we talked about MRI earlier, and the problem with MRI is that really you need a cholesteatoma more than 3 millimeters in diameter to have a sort of 90–95% chance of picking it up. So MRI won't help you here either if it's a small cholesteatoma. So I think this is a difficult problem. And actually the case that I'd offered to discuss, which I think we don't need to get to now, was exactly this dilemma of when do you decide to operate on an attic retraction pocket? And I am concerned about this one. So I guess what I would do is have a careful look at that pocket endoscopically at the time of putting a grommet in. And the grommet's going to have to go in that posterior inferior quadrant, I think, because there isn't anywhere else really to put it.
Okay. Will, is there a right answer to this?
Well, what I did was, so I had exactly the same view. This is an unhappy drum. I like that. I always like that phrase, an unhappy drum. And you've got some widespread atelectasis. You've got anterior retraction, and that I don't like anterior retraction because that's always a bad sign. And you've got this attic where certainly there's nothing going on in it, but it's got a deep pocket, and you can see the invagination. So the hearing was 30, about 30, so would go with blue ear. So I took it to theatre. I put a grommet in. I had a look with an endoscope, and the attic retraction looked like it did. There was no hugely deep fingers going in, but you've still got a degree of quite deep retraction. The grommet actually brought the hearing up to about 20, 25, so not normal, but okay. And currently, and then I had a conversation with the parents, which is, we've got an attic retraction. It's difficult to know. We may come to surgery at some point. And so we decided together that we would watch this attic, even though it's grade 4. It may not come to anything, or it may. And so I say to the patient and the parents, look, we can watch, and it may be we come to surgery at some point, but I can't tell you. So at the moment, we're watching this with a grommet.
Okay, excellent. Now, Will, are there any other pictures you burningly want to present? Because I'm okay, great. Because I'm thinking we should probably move on now to Susan's section. Is that all right with you, Susan?
Yeah, that's fine.
Great. Now, do you want me to present the slides on here that you sent me? Or
yeah, so the only question is, I sent some additional slides with some other scans.
Yeah, those are at the end. The
at the end.
1, 2, and 3.
1, 2, and okay.
That's.
I think you're on to. Oh, right. Okay. Okay. So if you start with the very first.
Yeah.
Okay. So I'm sorry. I didn't have an endoscopic photo for this. It's the right tympanic membrane, and so I should probably just start with, what do people think about this drum, provided you can see enough of it. Otherwise, I'll have to tell you about it.
Okay. I'll start with Keith. What do you think, Keith?
It's a limited view. I think it's a right ear, and I think the anterior TM looks normal, and the posterior TM looks different. Could be something white behind it.
I could tell that.
Can't see the attic clearly.
Okay, there is something white behind it. So history is he's 5 years old, presents with something white behind his right ear, been having some recurrent ear discharge. What would your go-to investigations be?
Is this an intact eardrum? We're thinking congenital cholesteatoma, or it's been running? Did you tell me there?
It's been running.
It's been running.
Yeah.
Okay. So it looks more than simple AOM with discharge if there's a white mass there behind the posterior tympanic membrane. So so depending on the age, CT's quick, readily available, multi-slice scanner they whiz through in a minute. So that's probably my go-to if this is urgent. MRI, better soft tissue resolution, but in a 3-year-old, it might take a sedation or a GA. So I'd be wary of that. But
okay.
Cross-sectional imaging, probably CT.
CT, okay. And, okay, so potentially if we go to the next, I think we'll just have to go to the next slide because I haven't got a picture of his other ear. So the original picture, when he was 5, he presented with the mass behind the drum. And this is 2 years later. So I haven't given you a lot of information in between.
Yeah.
But all the scans are his scans. So if you tell me what you think about his scans.
Okay, Adrian. Should we stay with Keith? Yeah, go on, Keith.
So there's soft tissue filling the right external auditory canal, and you can see it abutting onto the shape of the tympanic membrane. And unusually the air-containing middle ear space looks relatively preserved there. So that's a little unusual. I'd want to see the slices above and below.
Yeah, so do you want to go through the other radiology?
Yeah, definitely.
So if you just skip forwards to the ones that have,
These ones here, yeah?
Yeah.
Great. So you've got that one, and that one, and that one.
Right. Goodness. So this is a very unusual temporal bone. There's funny ground glass appearance here on the right side on the coronal images.
So,
very unusual.
So the original picture, he did have cholesteatoma on his right side.
Right.
And he had a combined approach on that side. Sorry, go back. Yeah.
This is post-surgical, isn't it?
Yeah, so so on the right
Oh,
side
I
is
see.
post-surgical.
There's a cortical mastoid, yes, okay.
Yeah.
But the left side is not.
And then the left side isn't. So he's presented now with in fact the identical appearance of what was on his right ear. Age 7, he's now got the identical appearance on his left side.
Wow.
So
Okay.
he's already had combined approach. And in fact, we were that's another child. We were investigating him for possible recurrent disease. Initially, he had a DWI MRI. So the question is sort of, what do you think about his ear? What would your advice to his parents be? How would you manage it?
So it sounds like he's the 1 in 10 with bilateral disease. So he said surgery in the right side. Often when they present this young, it can be more aggressive too. So we assume he's got bilateral disease, and we have to address the other ear. We have to look at the hearing very carefully. It looks like there's a disease in the initially operated ear as well. It's a wee bit hard to see on those coronal scans, but I'd want to go through them very carefully. Maybe examine that ear under anaesthetic. And the left ear is full of soft tissue there in the intrusic space and right up to tegmen.
Yeah.
So we'll have to address the other ear now.
So, Susan, what happens next?
What happens next with this? Well, I suppose really it's so what we did for him was have a long discussion with his family, because at that stage he was 7. He'd already had mastoid surgery on his right, and I was telling that he needed to have that on his left.
Yeah.
So it's really from the panel, what would your preference be for a child with, so he had a canal wall up on one side. What would you be thinking to do for it? So he's got cholesteatoma. It's shown on the DWI scan. He's got normal hearing on the left side. He did have a significant loss on the other side, and I think both his incus and stapes were destroyed. He's got normal hearing on the left side. So it's sort of, what would your preferred surgical approach be, and what advice? His parents are concerned about his ear discharge, but also about his hearing. So what would you be thinking about? What would you be telling them about that? How would you manage that?
I'll do a quick answer. Yeah, so quickly, I had one like this recently. I suppose one of the concerns would be the better hearing ear. If you've got a low mill stage on that side, go in there quickly, preserve the chain if at all possible, and try and keep that as the better hearing ear. Another argument would be go for the recurrent disease size, but more recently I chose to try and save the better hearing ear and keep the chain intact, and then 6 weeks later go back and tackle the recurrent disease there. But yeah, these are unfortunate because you're talking about 2 surgeries maybe in each year. You have to bring these families with you and counsel them carefully.
Okay.
Adrian.
Yeah, that would be my strategy as well, Keith. And I think from the trainees' point of view, those that are listening, we're taught, you never operate on a better hearing ear. But I think maybe that rule, if you like, comes perhaps from otosclerosis surgery from the days when there was no comeback. If you caused a dead ear, you didn't want to operate on the good ear. But here, if we don't operate on the left ear, this child will end up with hearing loss. If we do operate on the left ear, they might end up with good hearing afterwards. So you need to do the surgery to prevent hearing loss developing. And you can see on the scan that there's no disease in the oval window, which is so that, the stapes is clearly okay at the moment. You can also see that the disease doesn't, there's a bit of an air gap between the incus and the facial nerve there. So it's quite possible that you'd be able to peel a cholesteatoma off, leaving the acicula chain intact. Probably you're going to need to do a combined approach tympanomastoidectomy to do so, because it certainly looks like that's cholesteatoma in the mastoid, the way it's all scalloped like that. And I think you said, Susan, from the MRI, it lit up as well. So we're assuming that's cholesteatoma, yeah. I would definitely not do so. And then another rule that at least people often come up with here, I don't know about in the UK now, but was, you shouldn't do canal wall up surgery for bilateral disease. Well, I think that's, again, incorrect. that's a rather paternalistic approach. You need to have you need to inform the parents, and if they decide that they want multiple surgeries to try and leave the child with a normal ear, then that's their choice, so long as resource allows. And you definitely want to try and avoid bilateral mastoid cavities in a 7-year-old. I've had a couple of patients that I inherited that needed about 10 examinations under anesthesia to clean their cavities because they couldn't tolerate having it done awake. So we definitely want to avoid canal wall down surgery in children. If you were forced into doing canal wall down surgery, leaving a big cavity, because let's say most of the canal was eroded as well, as you do sometimes see that in young children, then performing an obliteration procedure is going to be the appropriate option. But the other reason, of course, not to do canal wall down if you could help it here is because you'd have to take out the ossicles, whereas we're hoping that we might be able to preserve them. Okay. And I agree with you, Keith, that you do have to take the parents on that journey. They need to be prepared for the fact that multiple surgeries are likely to be necessary.
Well, anything to add?
No, I would agree. I would counsel the parents and I would say, we need to get on because we'll be seeing each other a lot over the next 10 years. Mm-hmm. Let's be friends. I would go immediately for the left ear. I would do canal wall up because mastoid misery is not what you want, and that just ruins the relationship. I totally agree with Adrian. It looks like stapes is viable, so you want to stay with the stapes, even if you have to take out the other ossicles. Mm-hmm. You then got the stapes to use. I would probably counsel and I'd start a Baha soft band preoperatively, because it's likely with a canal full of packing, even if you leave the ossicles in, you're going to have a period where they're going to have quite a significant bilateral conductive hearing loss. And so I'd go in early for the left, try and sort out the disease. I'll then go back to the right, I'll do the right, and then I'd leave it 9 months and do the left again.
Okay. Excellent.
You can also consider doing a relatively conservative second look. If you with the endoscope, I have on a few occasions done the contralateral second look with an endoscope at the same time as surgery on the other side. So just a small incision behind the ear to look into the mastoid and elevated tympanomeatal fat. It's very low morbidity, very low risk, and allows you to get the 2 operations done under 1 anaesthetic. So it could be, depending on how bad the first ear is, you may be able to do that.
Okay. And this is where the KTP laser is great. Using the KTP laser, if you've got intact ossicles, you want to use the KTP laser. In terms of residual disease, you get a far less percentage of residual disease, and you can operate on an intact testicular chain. So if the chain's intact, that would be the perfect time to laser, take it all off the chain. You've got a clear facial nerve, and so using the laser is not so much of a worry. And you want to paint those ossicles and just really try and be conservative if you can. If you've got to take them out at a later stage, at least you've tried.
Mm-hmm.
Okay. So
great.
Yeah, thank you. So that is what he had done. I did his left side, preserved his chain, and then went back and did his right side. And his parents are going on that journey. Yeah, they are going on that journey. So the second case. So this child also had surgery when he was 5. So if you just go ahead, Mike.
What are we looking at there exactly in that?
Yeah, so what we're looking at is his right tympanic membrane.
Okay.
And the reason that I've presented this one is really that question of what we do about hearing. I think the view is not very good. It is the left side. What do we do about hearing in a child who has erosion of the ossicular chain? Yeah. So this is a child who presented with retracted drum, cholesteatoma, had a combined approach, and then after his first procedure, within about 6 months, because I'd put in I think it was a TORP that I put in, a titanium prosthesis, and then that's been eroded with the cholesteatoma on the out. So this is on the outside of his drum. It's just eroded straight through. So I've taken that out. If you just go to the next slide.
That one or the next one?
Yeah, no, this one. So I do the combined approach, and I tend to use the endoscope to look around the corner so that I can get a good view. So that's what the other pictures show. But it was really just to discuss with the panel, because I know we're short on time. What's your preference for preserving or restoring hearing when you go in for cholesteatoma surgery?
Will, do you want to start on that one?
So my preference is if the chain's intact, I try and leave it intact. I'll use the KTP. If I have to disrupt the chain, so if I have to take the incus out or the malleus out, I'll leave the stapes. I'll always do a cartilage reconstruction. And usually, if the stapes is fairly disease-free or I'm reasonably happy, I'll probably put on a PORP at the time of the first look in order to support the graft and also to give some hearing. If there's a lot of disease in the sinus tympani, or if there's a lot of disease around the stapes at the time of the first look, I might well not put in a PORP because I don't want to do too many things, because I'd much prefer a pearl to take off. If there is loss of stapes, I will never put in a TORP first time around, because when you graft with cartilage, you do not know where your cartilage will end up. You don't know if it's going to lateralize or medialize. If you medialize cartilage with a TORP behind it, unless you're very careful and you use a Dornhofer footplate, you can push the forces of the middle ear extremely strong, and you can push a TORP through into the vestibule. And I know a couple of people who've got slides of the TORP in the vestibule after the first look, if you're putting a TORP in straight away. So no stapes equals cartilage reconstruction. I sometimes put something on the promontory to support the graft in the lower aspect. And then when I come back, if there's no stapes, I'll then do I know then that the cartilage has stabilized, it won't medialize, and it's in its normal place. I'll put a TORP in there, but always with a Dornhofer footplate, because I want to actually spread the load as opposed to the small foot of a TORP going right on the footplate. If I haven't put in a PORP, I'll do a PORP at the second look. I'm not a great reconstructor on the first. If there's a lot of disease around the stapes, I'm not a great reconstructor on the first look. If the stapes is relatively clean, then I certainly will. I'm not expecting that to be the end hearing result, because I'm going to go back, and if necessary, I'll break that all down and reconstruct it again.
Okay, Adrian.
I'll try and pick up on differences rather than repeating the same stuff. I try and preserve the ossicles. Always try and preserve the stapes if it's there. I don't use a PORP actually. I almost never use a PORP. I just do a cartilage meningosteopediopexy. If you think about it, when the retraction disease that's eroded the incus, the level of the eardrum is at the level of the capitulum of the stapes. The malleus handle is often a bit medialized, and so I can't understand how there's actually space to put a PORP in, especially if you're protecting it with cartilage. So I know it's, I know people do it, but for me, I just use cartilage meningosteopediopexy, and about 70 to 80% of kids get hearing within the normal range doing that. I, like Will, don't put a TORP in at the first stage for various reasons. One of them is that it's quite unstable. If you've got a loose piece of cartilage graft that you're putting in and a loose prosthesis, those two things together are too wobbly, and I just find that an unstable reconstruction. I find it much easier or a more stable situation to do it at the second stage. And Will, I'm delighted to hear you talk about that risk of prostheses slipping inwards. Although it's not something that I've seen post-operatively, I have heard about it, and I do worry if we put these, titanium pointy things on the stapes footplate, they're going to be there for 70, 80 years perhaps in some patients. What percentage of them will erode through the footplate in that time? We don't know the answer yet because they haven't been around for that long. And so I do get consent from when I take consent from parents, I do discuss that unknown, probably small but serious risk. And it's amazing, actually, how when we're talking about this before their second surgery, a high proportion of teenagers and their parents decide they don't want an ossiculoplasty because they don't really feel they have enough of a problem with their hearing to want to take any kind of risk at all. Maybe it's maybe it's the way I explain it, but it does seem that children do adapt to a moderate conductive hearing loss better than one might imagine. Yeah. None of them want to wear a hearing aid either.
Yeah.
Maybe they should, but I have difficulty convincing them.
Keith, have you got anything to add?
I'm type 3. If the stapes is there, that's great. I'm more conservative than the other guys. I haven't put a torp in 10 years, so mine get a hearing aid for school use. And they wear it at school. They don't all wear it at home. But I take torps out sometimes that other people have put in the middle of recurrent cholesteatoma, but I don't place them. The results are pretty atrocious with torps, are they not? It's less than 50-50, isn't it?
Yeah,
it is less than 50. One thing that I found really helpful is a Dornhofer shoe, and a Dornhofer shoe is a little boat, and it's almost entirely fits into the round window niche, the oval window niche, and sits on the foot plate with a little cup to put the end of the torp in. So it also stops the torp moving around, because what you don't want is, if you don't put something on to hold it, it's like putting a pin on a flat surface. It's gonna wobble around. So the Dornhofer shoe is a really nice thing if you're going to put a torp in, and also it spreads the load across the foot plate, and so you're not going to have a sharp, pointy thing, as Adrian says, on the stapes foot plate, on a bony foot plate.
Are many of you considering the use of Bahas in these sort of kids, or is it not normally that big a problem? Anyone?
Bilateral conductive losses, yeah.
Okay, yeah.
I think it's hard enough trying to persuade them to wear an ordinary hearing aid.
Okay, fair enough. Okay, Susan, what else would you like to say? Anything?
No, I mean, I'm probably not as conservative with using prosthesis, partly because, my typical patient will say, oh, it's great. But I treat adults as well as children, and they'll say, oh, my ear doesn't discharge, but my hearing's not any better. So, but it doesn't, part of it is accepting that it doesn't always work. Thankfully, I've not had any that erode through the oval window. So if you just go forwards with that.
Can I ask you, Susan, do you think your adults complain more about their acquired loss than the teenagers do? I wonder if it's harder for an adult to adjust to it, and one of the reasons that the kids don't complain is because they're more plastic and they just get used to it.
Yeah.
Do you think that's true or not? Maybe Will as well, if you both do adults.
I think it's quite possible.
Yeah.
So I think often the adults are used to hearing on that side, and so therefore they notice their loss more. The other aspect of children is I think they do adapt better. But the other issue is, as you mentioned, Adrian, is that you start to talk about a hearing aid, and most teenagers blanch and start to go a bit wobbly and say, no, God, no. Now, I would be very interested to know if in 10 years' time, when they're 25 and they need to actually have a job where they have binaural hearing, whether they go, do you know what, I'd quite like a hearing aid. And so I think a lot of it is they hear the options and they hear the word hearing aid and what it'll do in terms of their social group, and they get on with it because they don't want to look any different.
Yeah, and the problem is when they start trying to wear a hearing aid at 25, they've lost their neural plasticity, and now the hearing aid's not really going to work because they've got one dominant ear and one that's useless. So it's tough trying to explain all this stuff to them, isn't it?
Yeah, I think the transfer of information is really hard because you have a lot of information to give and experience to give, and you need to bring them up to a very high level in order for them to truly appreciate that.
Okay, thank you. Susan, do you want to go through the other slides here, or are you okay?
No, the other slides are quite similar. So this is just the endoscopic view of looking at his ear. And if you go to the next one, this was
What are we looking at there exactly as a non-otologist?
So what I've done is gone to the sort of behind the epitympanum area with the scope. Because really what I'm doing is going around the corner to ensure that there isn't any disease there in all the nooks and crannies. And that is where I find the endoscope most useful.
What's that bulgy thing in the bottom right-hand corner?
Bit of bone. I haven't got a name for it.
Oh, okay, fine, sorry.
It's from the mastoid end. It's not the...
Oh, I see, it's not a thing, right. Okay, good. And this is all much the same sort of thing, yeah.
It's just going further around the sort of behind the epitympanum. So in fact, here you're just over the back end of the facial nerve, aren't you?
Okay, well,
from the mastoid.
Your word for it.
The facial nerve is, I don't know if you can see my browser, but the facial nerve is sort of anterior inferiorly, the horizontal portion.
Okay, yeah.
I believe you that I have say.
Yeah.
Just go to the next slide, Mike.
Yeah.
So
it's okay.
So
the others know what they're looking at.
This is a canal view.
Yeah.
Because he had so much disease, it was just clearing off all of that. So on the other view, I've gone behind that, and this is from the canal view.
Right.
Yeah. So for him, because everything had eroded, then what I've done is grafted him, and he's settled. So we'll see what happens when we go back in and have a look.
Yeah.
Yeah.
Let's say you're quite keen on your cartilage grafts, and I've seen quite a lot of them over the years, and the ones I've seen of yours are all in the right place. They're lovely and solid. I've not seen any that have come out or anything.
That's good.
No, it's great.
I've got a few of those.
Excellent. Okay. Anything more to add, Susan, or shall I move on to Keith?
No, move on, please.
Oh, that's lovely. Thank you very much. So it's quarter to 9. Are you guys still all right? I mean, I'm absolutely fine. We've still got 38 participants, so I'm happy to keep going. Yeah. Yeah. Keith, right.
I'm gonna try and share my screen, Mike, and see if it
works.
Right.
So I'm going to end the share here, and you can share it directly from yours. Yeah.
So share. Does that work for you?
Yeah, I think everybody's got that. I think you could probably now do a what do you call it? A slideshow.
Okay. Is that full screen view now?
Not quite. I've still got.
I think you see the slideshow button at the
Okay. I've clicked it. I can click it again. How's that?
No, still what's it view rather than slideshow. Just
resume slideshow.
You try clicking on use presenter view, Keith, and then it might allow you to switch your screens.
Okay. I've got so many screens open here.
Sorry.
From beginning slideshow. What about that?
That looks good.
Okay. Right.
Then,
this is
Keith, at the top it says I can't quite see. Is there a thing top left? Is there a thing to switch your screens?
Oh.
Under display settings or
stop video, new share. I'm screen sharing. You want me to pick a different screen?
Where it says display settings, does that give you an opportunity to switch your screens?
Swap.
We haven't got
that?
full view. That's it.
Good man. Thanks for taking me through that. Right. So this is a nice segue from the foot plate that Will was talking about. This is another Stapey's foot plate case. So one of the large sections for the trainees in the curriculum in paediatric ENT is congenital deafness and congenital abnormalities of the ear. So this case sort of nicely covers both of them. This is a 12-month-old female. We were asked to have a look at with a second episode of non-meningococcal meningitis. She had her first episode at 6 months. And the context in the background was the child was being worked up for congenital SN hearing loss after failing their newborn screen in another hospital. So in the second episode of meningitis was fairly devastating. There was pneumocephalus, widespread changes in the brain. And it was just a shame we hadn't picked this kid up maybe 6 months earlier. But the imaging was carried out in ICU. You can see an axial MRI over on the left of your screen there with some high signal intensity filling the middle ear mastoid on the left side. And then there's a zoned in left temporal bone CT there on the right side of the screen. So something going on with the left ear. ENT trainee called to ICU. Second episode of meningitis. ENT, come and fix this and stop this happening again. So what would the panel be thinking about this SN hearing loss, second bout of meningitis? First episode was H flu, second one was strep pneumo.
Okay.
Child's otherwise well, a grade 1 microtia on that left ear externally, so just a slight change on the shape of the pinna. Otherwise twin, born at term.
Okay, Will, do you want to start?
So, dealing with the CT first of all, axial section through what looks like a very abnormal cochlea. And so this looks like a really quite a marked dysplasia, almost common cavity. Yeah. It's unusual because you've got a very wide, what looks like oval window niche. You can just about see the facial nerve going across the top. We're at the level of the incus and malleus head, so we're quite high there. We've got soft tissue, well, we've got a pacification of the middle ear cleft, medial to the ossicles, but we've got some aeration laterally by the looks of it. So the question, I suppose, in terms of the middle ear, looking at the middle ear, Keith, was there fluid behind the middle ear?
Yeah, it looked like glue, barn door, glue ear on the top.
So in that case, what it's looking like is we've got some kind of quite marked cochlear dysplasia. Difficult to see what's going on with the lateral canals. On the MR, on the right-hand side, you can see the lateral canals, the vestibule, the IAC quite nicely. With a slightly different cut on the left-hand side. And so we've got a lot of signal, and so it's difficult to see how much of that is fluid, how much is not. But difficult to see the vestibular. But he's got a marked what looks like common cavity. Or she, yes, is it she?
She, yes.
So it'd be more usual to have a common cavity in boys, but
yes, I'll show you other cuts will make it clear. But you're spot on there so far, and. Yeah, so what on the MR, Will, what do you think of that asymmetry, of that very hyper-intense fluid filling the left side?
I'd want to look up and down. I want to look up and down because it's definitely abnormal. The question is exactly what's going on. So it'd be nice to have a look up and down on those cuts.
If I show you the next slide, I'll show you the answer. But so be it. So if I go down to the another axial. Would you like that shot there? But the upper one shows you the vestibule nicely. Well,
so big bulky vestibule. That's very abnormal vestibule, and also it looks like a widened IAC. So again, you'd like to look at the cuts up and down, and so you'd be wondering. So again, you can't see so well the canals coming off it. And so it could just be there's a common vestibular cavity together with a common cavity in the cochlea.
It's not even forming a basal turn there, as you can see. No medalis.
I can't see the bottom bit so well.
Yeah. So So anyway, so ID ask us to fix this child. So I think from trainees, you're maybe think. There's a routine that pediatricians go through, asking about head injury, checking for spinal defects, looking at the organisms to see where this could have come from. But I suppose for me and T, we want to be clued into the risk of a CSF leak and an ascending meningitis in a kid with a severely dysplastic cochlea. So we aspirated the fluid in ICU. The child was very unwell. It was watery fluid, positive for beta-2 transferrin. And we have the option in Belfast of phoning a friend, who I think was Blake or Adrian, who taught me this word last year, cochlea seal. Now, I hadn't heard of this before. Adrian, did you invent this word, or had someone else coined it?
I think it was one of our radiologists, actually, Manu Schroff. I don't know if you remember him, but he mentioned it like everybody knew what one was.
Right.
When we looked it up, we couldn't actually find any reference to it, but that's what it seems to be called. So.
Fabulous. So I learned a lot through this case. Anyway, ID are telling me, don't let this happen again. Patch this kid's ear. So here's a view from an endoscopic ear procedure with the incus lifted out. So we've child is stabilized. We've gone to theatre with a tip from Toronto that this is easily fixable. And a little sickle knife has gone. Here's the horizontal facial. The posterior arch of stapes and the tendon was here. The anterior arch was gone. And there was a fairly wide defect of the foot plate with this cystic thing popping out of the foot plate. Wee bit of granulation around the middle ear. Here's manubrium of malleus, neck of malleus here. That's the articular surface with the incus, which is now gone. And we've just run a little sickle knife in, and the fluid is just seeping out of this space, and then packed it with temporalis fascia. I have a little bit of gel foam, I think, sitting here, and then we just slide it in and pack it between the stapes and the fascia. And I think it's about 11 months later. She's had a bit of glue ear on that side and AOM once or twice, but no further problems from CSF leak or meningitis. So I guess the important thing from our trainees, we're not going to talk about classifications of cochlear dysplasia, but remembering this particularly severe one, the IP1, with the empty cystic cochlea vestibule, there isn't an enlarged vestibular aqueduct like you get with the Mundini or the IP2, and a defect between the IAC and the cochlea. So the leakage intermittently into the middle ear is the portal for infection, and then the meningitis risk. They often have a profound hearing loss with the IP1, and hearing aids often aren't enough. And they're implants for cochlear implants, which of course leads on to another whole list of potential complications. But the tip for the trainees, I suppose the pediatricians have a role in identifying a second bout of bacterial meningitis, in not letting them leave the hospital, full examination, calling ENT, I suppose, at an early stage. And we want to look at the newborn hearing screen. We want some ear-specific hearing assessment. We want good quality imaging of the temporal bone. And then hopefully the alarm bell will go off and you'll go after the leak and fix it. And arguably, the image I've put up here was the CT at 6 months when the child came in with the first bout of meningitis. And in hindsight, of course, you can see the severe cochlear dysplasia on the left side, as Will quite rightly mentioned, with the wide oval window defect and the cystic cochleovestibular malformation. So it would be nice to get it before the morbidity of the second severe meningitis. So any comments from the panel? Adrian, you've had a couple of these cases, so you know all about it. But I like that little terminology of the cochlea seal, and was delighted it was a fairly straightforward thing to fix.
It's a good thing to be aware of, isn't it, about the risk of meningitis with these anomalies. The one that I had, the mother made the diagnosis of CSF leak because she noticed when she lay her kid down on one side, water dripped out of the nose, and she looked it up and tasted it, and it was salty. So she went to the doctor and said, "Oh, my kid's got a CSF leak," and sure enough, they had.
Wow.
That's not the way it works in Belfast.
No, the doctor said it was go away. It's just a cold, but she persisted, luckily. Yeah.
Is anybody else jumping around like they're in a disco, or is it just my computer? No, it's just mine then. That's fine. Good.
Jen, is that always, because there are different abnormalities that can occur, would that generally be the way to correct it, by closing the oval window area, or are there other sites that you might want to look at depending on the level of the abnormality?
This seems to be the classic defect with IP1, looking back over the literature.
Okay.
Adrian had a few of them. I think were yours all foot plate related?
I think we had 3 and 2 children, and the one with the bilateral disorder had a cochlear implant on one side to try and get some hearing, but it didn't really work very well. I think the nerve was quite hypoplastic as well. Mm-hmm. But I think, if you read the books, there are things like Hertel's fissure and various obscure places where it seems like stuff can leak. I've not had experience of any other site of leak than this. Yeah.
Okay, that's good to know.
If they've got a cochlear abnormality, it's most likely. If you look at, again, the books will say that it's more common in boys, where you have a dehiscence at the lateral end of the IAC. We've had a couple of bilaterals like this,
That's
X-linked. That's X-linked.
That's the Phelps thing, isn't it? The type
Exactly.
3, where you have quite a different appearance of the cockpit with no, what would you call it? And the dialis is completely missing. So,
correct.
Yeah.
And so we've had a couple of both boys and girls with quite marked cochlear aplasia who we've implanted, and the issue has been that there's been very little mastoid, and also by putting an implant in, you create a CSF leak, and actually it's usually a gusher when you put it in. It actually starts to fill up. So with those, we've had one. We've just had one or two. And the one we've done recently, where we've done a blind sac closure on that side, and so you blind sac it, you block the eustachian tube, and then you implant to try and give them some hearing. And actually, that's worked quite well. And so he's actually got reasonable hearing on the side we've implanted, and the other side where we're not going to rush into. So the other option is blind sac.
Okay, right. That's fascinating, Keith. I must say, sticking a knife into the oval window strikes me as being quite a hairy thing to do, but you clearly knew what you were doing there. Were you slightly anxious about it at the time, or were you pretty calm?
I told you we used the phone a friend option. So speak to Blake and Adrian James, so they know about all these things.
They told you what to do.
I've seen them before.
I'd heard about it from Brandon Isaacson in Dallas in Texas. So like you say, Keith, it's always good to phone a friend.
Yeah, that's excellent. Right, Adrian, Keith, have you finished your screen share? Adrian, do you want to do yours from your laptop?
If I may, thank you,
yes. So Adrian's going to talk to us about endoscopic ear surgery, which is something I have a little bit of a knowledge about, because I did go to Dave Pothier's ear course in Toronto when he was running it. And of course, Dave is sadly no longer with us, but Adrian is doing a lot of endoscopic surgery. Adrian, are you running a course still?
We aren't actually. There are a lot of courses all over the place now, and so you know, in the UK, that I know there's Aaron's course up in Glasgow that I think is good, and I think there are other courses in the UK as well. I think up there in Birmingham or London possibly. So I think there are lots of opportunities for go-on courses, and I think that is the way to learn, as you say.
I must say the Toronto one was absolutely excellent when you used to run it. You know, with the
well, thank you. But the trouble is, it's a long way for people to come from Europe, especially if you've got courses closer to home, and all the guys in the US want to stay down there. So we didn't really wasn't popular enough. So
Okay, well, I'll leave you to
my screen, or can you see my screen?
We've got you. That's absolutely fine.
Oh, perfect. Okay, so the screen doesn't. Okay, good. So I should actually start by paying tribute to Dave Pothier, seeing as you mentioned him, because he is his enthusiasm is what got me interested in the opportunity to do totally endoscopic ear surgery. And without him, I'm sure I probably still wouldn't be doing it. So I'm going to talk, Mike, you said to talk for up to 10 minutes. I'm
that's fine.
Planning on it being less than that.
Okay.
And basically, it's only a very brief introduction, really explaining what it is, what the benefits might be, and then just one very short clip of video on tips for how to do it. And this little video here, I think, is perhaps the best way of showing how an endoscope is useful. If you want to take a picture of this tree, you don't hold your camera on the outside, you move your camera beyond the narrowest point, so that with your relatively wide-angle lens, you get a good view. And if you want to see around the corner, you don't make a hole in the wall, you change the angle of your camera. And this analogy is very well suited to understanding why we use an endoscope for ear surgery, because we can put the viewing lens beyond the narrow part and see well. From this illustration from Starabici. Now, there are some people who still don't really identify with these endoscopic advantages. This drawing is a modification of Tarabici's illustration by Mario Sanna's group, of the Gruppo Italiano, and because they say, well, if you drill a bit of the bone away in the canal and move your microscope around, you can see just as well in the middle ear as if you use an endoscope. And to some extent that's true, except you have to move your microscope around a lot to see. But of course, it's not true if you want to see around the corner. With an endoscope, you can see in here with an angled endoscope very effectively, but you can't with a microscope unless you do much more destructive surgery and remove more bone. I want at this point to emphasize that there are two different kinds of endoscopic ear surgery. And the first, which was really promoted by Jean-Marc Thomasson back in the 90s, is to put the endoscope in to have a look or to help you with parts of the surgery that are difficult with the microscope. So we could call that endoscope-assisted surgery, but the enthusiasm really over the last decade, perhaps 20 years now, was promoted by people like Dave Pothier, is in using the endoscope alone without a microscope for totally endoscopic ear surgery or transcanal endoscopic ear surgery. And that's really what I want to talk about. The way that I sort of first started to it was just like Susan was saying, actually, was just to have a look in difficult spaces. So before we had an endoscope, this is a second look in a right ear with the tympanomeatal flap elevated. To look in the retrotympanum, you can put in a bit of saline and look in the meniscus, and you can see there's a little bit of residual disease there in the facial recess just here, but you can't see it very well. You certainly couldn't remove it with this technique. You can put in a mirror, and again, you can see it pretty well, but it would be hard to remove without removing bone. And so the obvious thing to do is to put in an endoscope. This is a 30-degree endoscope. Now all of a sudden the facial recess isn't a recess at all. You can see it perfectly clearly and remove that disease in a quite effective manner. So that's what I started doing. And then you realize that, well, why not do it for your dissection in the first place? These two bits of video from the same patient from a left ear, and on the left-hand screen, you can't, this is the round window niche that you can just see, and the tip of these curved instruments disappear out of view. This is the same dissector in the, with the endoscopic view. The round window niche is now at the front of the field of view. We can see into the sinus tympani perfectly, because it's quite a shallow one in this patient, and peel the skin out to the sinus tympani and off the pyramid. The pyramidal eminence is here, the staphy superstructure is coming into view. We can do this under direct vision and know that we've not left any residual skin behind, and so potentially reduce our risk of leaving residual disease. And then once you've figured out that you can do that through a post-auricular incision, you realize, well, actually, you can do it through the ear canal without making an incision at all. But so there's a lot of enthusiasm, but interestingly, if you look critically at the results that have been published, and I'm mentioning, you know, these are my data that are available, but there are meta-analyses now of looking at several studies in children as well as adults. You'll see that actually the results aren't that dramatically different. Repairing a perforation is the same, whether you do it totally endoscopically or through a post-auricular incision. Results from torpessiculoplasty are the same in terms of hearing outcomes. When we compare endoscope with not using an endoscope, we do get less residual cholesteatoma in the middle ear space, but overall, that's not a very strong effect. It's a fairly small difference. When we compare totally endoscopic ear surgery with endoscope-assisted surgery, there's no difference in residual cholesteatoma. So you kind of look at this and you think, well, what's the point? If the results are the same, why would I struggle and try and do surgery endoscopically? And this is the answer. It's because by doing surgery endoscopically through the ear canal, there's less morbidity for the child. And first of all, if we think about wound complications, they're pretty rare, aren't they? You know, we all know as surgeons that a post-auricular incision heals up pretty well and is actually, from a surgeon's perspective, a pretty trivial intervention. But a proportion do get complications. And here we see a seroma, a wound dehiscence from an abscess that's now starting to heal up, and a wound dehiscence caused by another kid in the playground pulling on the kid's ear because he thought it would be funny after surgery. Those are some examples, and in my practice, it works out about 1 in 25 or so end up with some sort of wound problem. When people put the incision in a visible place, and particularly when they use interrupted sutures like has been done here and here, the scar is visible. I don't really think, well, I think it's entirely unacceptable to use interrupted sutures and cause that kind of scarring. much better to use a subcuticular suture, and preferably one that dissolves so you don't have to remove it. And I personally would hide it more in the post-auricular sulcus so you don't end up with this unsightly scar tissue. But sure, we can avoid that scar by hiding the incision a bit better. But the bigger issue is this, is occasionally you get a patient with a keloid. Here there's another complication of a fistula into the mastoid after infection. And I can tell you, this kid here had bilateral tympanoplasties with a post-auricular approach. And you could imagine the effect on quality of life that this awful complication had for him. We're taught that it's people of, particularly of African descent, that are particularly at risk of keloids, but this guy was from Sri Lanka. This one I can't remember, but looks pretty Caucasian. I think this kid was from the Middle East. I think this kid might have been from Sri Lanka as well. And this child was from China originally. So it's not necessarily, you can't necessarily predict who's going to get a keloid. And if you could avoid it, well, of course you would. There are some other advantages. Surgery ends up being quicker once you've got figured out how to do it, because you don't have to spend the time closing the incision. There's less pain afterwards. That's been shown in a few studies now. The length of stay is shorter because of these two things. But ultimately, the main driver for me has been parental preference. It always struck me in the early days how pleased parents were when they heard that I'd been able to do the surgery without making an incision. And I was kind of a bit mystified because, like I said, to us as surgeons, making a little cut behind the ear doesn't really seem like a big deal. But for the families, it clearly was. The reason, so then the question is, well, you know, why would you make an incision if you don't need to? And I think the reason for most people is because it can be quite difficult figuring out how to do surgery with one hand. But with patience and practice and attending courses like Mike was alluding to, you can learn tips that make it easier. And I just wanted to show this one video clip here about how you can do a lot of the functions that you'd normally do with two hands with one hand. So this is a curved suction dissector. You can see that we can dissect without retraction if we want to, but if we rotate the instrument a little bit, we can retract so we can see better. A sharp tip allows us to cut through that little strand of tissue there. And all the time we're aspirating blood so that we're maintaining a good view. And then with practice, you kind of get used to the idea that you can retract like this just by rotating the instrument a little bit. And that kind of keeps the tissue under tension so that when you're dissecting, you're able to, you're able to dissect by doing all these things at the same time. And it does take a while to get the hang of this sort of thing. It helps if you have specialist instruments like suction dissectors, but it's certainly possible to do it, to do the surgery with one hand like that. One-handed is in inverted commas because you may have noticed the endoscope was moving around all the time. We don't use an endoscope holder because we need dynamic positioning of the endoscope to see, to optimize our view. So it's only a quick summary really, but I think the main advantage of doing surgery totally endoscopically is that from the family's perspective, it's incisionless surgery, which they like. For cholesteatoma, perforation, repair, and vesiculoplasty, the results are at least as good as doing it through a more invasive approach. And we do have that advantage that the morbidity is less. So that's why I would encourage you to consider this option and to work at it. So Mike, I did have a case to present, but I think it's very similar to the sort of things that we were talking about with Wells. So
Adrian, that's fantastic. So when I came back from the course, I went through a spell of doing endoscopic myringoplasties, and I did a fair bit of it, and I even did a little aticotomy with cartilage graft. And you know me and my images and photos, I love that sort of thing, so it suited me down to the ground. But when the two departments merged, there were a lot more otologists, and I basically stopped doing it. But I thought it was a fascinating subject. I don't know, Susan, are you doing anything endoscopically, or are you sort of doing it endoscopic assisted?
So I think, so in fact, after I went to BAPO and saw quite a few of, I did the course in Harvard actually, because it's endoscopic sinus and an ear surgery. So I did that one, and then that talks a lot about your positioning. So having the screen in front of you as opposed to on the side, sitting. So I found that that's quite useful. So I'll do a myringoplasty endoscopically, and I use it a lot in terms of doing mastoid surgery. I think, and this was part of my question for Adrian, is would you do cholesteatoma surgery completely endoscopically in a child, particularly if you're doing a canal wall up? I'm not quite clear on how I do that without doing an incision, but the smaller procedures, yes, I would do.
Yeah, so I think, so you can imagine if you picture a small congenital cholesteatoma in the anterosuperior quadrant or even in the posterior superior quadrant, you could imagine how an endoscopic approach would be well suited to that, because it would help you to see into the area where it is. And then also, if you imagine disease, we don't see this very often in children, but disease confined to the lateral part of the attic, as Mike's saying, you can do a simple atticotomy. With a curette, you can remove the bone quite easily to remove the sputum. And so those would be the first step. Ultimately, if you carry on, you have experience of doing that, you go a bit further. I think the limit for most people is somewhere around the lateral semicircular canal, maybe the apex of the lateral canal or a bit behind that, because in order to get any further back toward the synodural angle, you have to remove so much bone from the canal wall. You're virtually doing you're doing a front to back mastoidectomy, and then you've got a big defect to repair. And the point I always like to make is that in children, if you're using tragal cartilage to repair the canal wall, well, in a young child, the tragal cartilage isn't that big, and so you might not have enough to repair the size of defect that you've made. So especially if you need to repair the eardrum with cartilage as well, that there isn't going to be enough. So you have to think about not just how extensive the disease is, whether you can reach it through the canal, but also how you're going to reconstruct it.
Okay.
Yeah.
Keith, do you use endoscopes a lot?
But assisted, for cholesteatoma. I haven't used the Buckingham mirror for 12 years. Yeah. But yes, I'm starting to use it. I think it's good. Yeah. And
Will, how about Southampton?
So mix. For certain things, the endoscope's great. So if you're doing, as Adrian says, if you've got a congenital cholesteatoma, anterior superior, middle ear work, going in and looking around, sinus tympani, fantastic. So very much same. I don't do much pure endoscopic surgery, but I think that actually you can mix both microscope and endoscopic together, and it works very well. So I think it's a great innovation.
Yeah, my experience was that it was quite faffy to start with, get to the graft, and then get to the graft in and then when you put the flap down, that was the operation over. You just put a little pack in, and that was the really nice bit, because suddenly you were done without having to stitch anything up, and actually the post-op morbidity and pain is really low, as you mentioned earlier, so it's quite an attractive thing.
I think it is quite true that parents love it. They love the idea of no incision. So
yeah, increasingly people are sort of worried about cosmesis and incision and scars, aren't they?
There's a question on the chat line.
Yeah. What does it say?
Any studies regarding doing endoscopic stapedectomy?
There are actually. Yeah. So of course, in children, it's very rare that we would consider doing that procedure. The risks of a dead ear, doing stapedectomy on a congenitally abnormal stapes is thought to be around 3%. So in other words, 1 in 30. And that's published results. You can imagine that a lot of people are a bit shy about publishing their bad results. So maybe it's even higher than that. So in our practice, we tend not to operate on congenitally abnormal stapes, and we don't really see otosclerosis in children. Although it's reported, we haven't seen it. So I don't have any experience, but it's definitely reported in adults. And there's some debate really amongst adult otologists, I would say, as to how helpful people find it. But there are some strong advocates who are capable of doing endoscopic and microscope guided surgery. who strongly prefer to do it with an endoscope. I think results are fairly equivalent, though.
I must say, my personal view on that, Adrian, is that the best treatment for otosclerosis is a Baha. But
I think it also depends upon your learning curve.
yeah.
I think that actually, if you've done microscopic two-handed stapedectomy for a prolonged period of time, and you've got over your learning curve and you're on your plateau, then there should be no reason to change, because to go back, you are going to have a learning curve and you will have morbidity. If, however, you're starting out and as a registrar you have access to consultants who will do both, then you can choose. And I think a lot of these things don't come down to technique, they come down to your own personal results. If your personal results, and this is why you need personal audit, if your personal results are up with either technique, then that's fine. But you do need to audit whatever you do to decide what's best.
Yeah, that's a great point, Will. And Dave Pothier was always mortified when people were rushing in. You know, they do a course and then they go home and do an endoscopic stapedotomy. He was always frightened that was going to give endoscopic ear surgery a bad name, because people would go home and get complications. So I think everybody would argue that stapes surgery is not how you start doing endoscopic ear surgery. Start on easy tympanoplasties and get experience before you consider doing stapes.
Okay, that's Adrian. It is fantastic, and it's very nice to see that that's actually progressing as time's going on. Can you end your slide share from it?
Of course, sorry. Yeah.
No, it's fine. Don't worry. I've just got a couple of 2 or 3 slides to put on as the usual advertising at the end. I'm just going to try and work out if I can do that or not. So we have set a record this evening, because we are the first of these webinars to go beyond 2 hours, which is quite an achievement. But it's been fantastic. So
it's still only 4:20 in the afternoon.
Yeah. Well, it's been really nice. I mean, I'm a non-otologist, and I've found it pretty interesting, apart from the stuff I was talking about, obviously. So the next thing in the important world of BAPO is the BAPO meeting in Birmingham in September. And Adrian, I don't know, but Boris Johnson, who is that well-known expert on infectious diseases, today reduced the social distancing distance to 1 meter. Is that right? Did I get that right, or did I mishear it? Yeah. So Mike has chosen a whole. Sorry.
From July the 4th.
From July the 4th. Well, this is going to be in September, so it might be down to half a meter by then. You know, we could be pretty much back to close physical contact.
You have to sit next to somebody on an airplane, I guess.
Yeah, exactly. So Mike's chosen a place in Birmingham where even if we had to have 3 meter distancing, you could still get 300 people in the hall because it's so enormous. So we were a little bit concerned that we might have to postpone BAPO, but I think the way things are going, it's looking pretty good. So I would urge everybody to put that in their diary and register and come along. Now, one thing that did get the old heave-ho because of the COVID epidemic was this year's ESPO, which was a great shame, but it has been moved to the 13th to the 16th of February 2021. And those of you who like cycling, obviously that's going to be no use, but if you like skiing, you might just be able to merge the study leave and holiday together, who knows. And of course, partly because the French one's been deferred a year, and for a number of other reasons, the Liverpool one has also been deferred a further 12 months. So we're going to look forward to that very much. Any final comments from any of the panel? I'm really very grateful to all of you. It's been
supper time.
Yeah, it is
supper time in Northern Ireland.
Yeah,
I'm always hungry, as you know, Adrian.
I was just.
It's really enjoyable, Mike. It's good.
You weren't eating during the session, Keith. I was surprised.
Mike, are you going to virtually feed us now? Because none of us have had supper.
Well, if I could just virtually show you half of the
Perfect.
Which
so you're all right, Jack.
Yes, I am. I'm going to have to put it in the microwave though, or feed it to the dog. but I was thinking of going to the fridge and getting some beer out. Tradition. After I've chucked a few more statues in the harbour, obviously. Okay. Right.
Mike?
Yeah.
Mike?
Yes.
We're on for tracheostomy in 2 weeks, okay?
2 weeks we're going to do tracheostomies, okay? So that's, yep, same time, 2 weeks, same place. That's very good. So, Will, thank you very much.
Mike, thank you for inviting me.
Oh, fantastic. Well, Susan, very nice to see you again. Thank you very much.
Thank you. Nice to see you all. Nice to meet you guys.
Yeah,
Thank you.
And Keith, thank you very much as well. And Adrian, thank you very much for making the journey from Toronto.
Yeah, do it without jet lag, actually.
Yeah, it's great to see you again. That's really good. So thank you very much to everybody. Night, night.
Yeah, thank you, Mike.
Good night.
Bye.
Good to see you all.
Bye.
Bye.